Hello everyone. Today we are talking about cardiac surgery. I think this is a very big topic for you, and first of all I think I should tell you some anatomy and terminology of the cardiac surgery. We have these figures like this. You can see the heart here, and here is aorta, pulmonary artery, right atrium, left ventricle, right ventricle, left atrium, and we can also find some valve, mitral valve, tricuspid valve here. And do you find any problems here? Yeah, we can some anomaly here. This is the VSD here, and the wrong connection of the pulmonary artery to left ventricle. So if you have time, you can find even more anomaly in this figure. And here we can find the conduction system of the heart like this. And this is the sino atrial node, and the whole conduction system is like here. So this is the simple terminology, and generally the heart disease can be divided into congenital heart disease and acquired heart disease, such as ASD, VSD, PDA as congenital heart disease, and coronary artery heart disease, and valve heart disease like acquired heart disease. Diagnosis depends on the history and the clinical examination, and also we need a variety of tools. And the tools should be included like this: brain radiography, and electrocardiogram, and echoes. The excellent anatomy detail may be obtained by echo. So this is very important tool for us. And also we need magnetic resonance imaging and cardiac catheterization, which is the gold standard to obtain the precise and dynamic information. And the congenital heart disease can be divided into a cyanotic and cyanotic heart disease. And here, first of all, we talk about the cyanotic heart disease defect. There are two models for this type of heart disease. One is increased in pulmonary blood flow. The other, we can see the obstruction of blood flow from ventricle, such as pulmonary stenosis, aortic stenosis. For the first one, we can see the ASD, VS, and PDA. ASD, this is the defect develops as the result of incomplete closure of the embryologic patent foreign oval. Most children are not overtly symptomatic, but may exhibit some degree of exercise intolerance or frequent respiratory tract infection. Symptoms typically become more prevalent in adulthood and include dyspnea on exertion, palpitations, and ultimately evidence of right heart failure. So this is the figure of the types of the atrial septal defects as viewed through the right atrium. We can see the ostium segmentum, ostium prime here, and the tricuspid valve. This is the coronary sinus, and the sinus venusus like this here. And the treatment for the ASD, the indication of ASD is ASD closure before school age. The standard therapy for ASD for the past 50 years has been surgical closure using cardiopulmonary bypass support. So this is the surgical closure for ASDs. We can see here is the right atrium, right atriotomy here. here is the direct suture closure, like this, is a rounding suture. And here is the patch closure, like this. We usually use the pericardium as a patch. And here, before the close of the defect, we need the airing, the left atrium. Otherwise, the air embolism will happen. Next topic is VSD, that is the ventricular septal defect. And VSD is a pathologic communication involving a defect in the interventricular septum. So this is the figure shows the location of the VSDs, and 1, 2, 3. 1 means the perimembranous VSD location here. The second one is the subarterial VSD, like here. And here is the atrioventricular canal type VSD. And this one is the muscular VSD. Surgical indication for VSD relate to the size of the VSD, the degree of shunting, and the associated lesions. Small babies presenting with large VSDs, refractory heart failure, and heart shunts undergo surgical closure of the defects in the newborn period, irrespective of age or size. Other defects are addressed based on the ongoing concerns of left-to-right shunting, aortic valve cascade distortion, and the risk for endocarditis. And asymptomatic patients with evidence of significant shunts and cardiomegaly are put forward for surgical therapy. Now we are talking about PDA. PDA means the patent ductus arteriosus. PDA closes spontaneously, being completely closed in most people by 2 to 3 weeks of life. If not, it's pathologic. Closure is recommended for all PDAs. That means all patients should be treated. Otherwise, pulmonary hypertension or the Eisenmenger syndrome will occur, and the pulmonary congestion and the left heart volume overloading, and also it can cause endocarditis. And here we can see the PDA here, patent ductus here, just between the aortic arch and the left pulmonary artery. And here we can also see the left lung, and this view is through the incision of the left thoracotomy here. Next topic is about cyanotic congenital heart disease. The typical example for this disease is phthalate, and these doctors are the pioneers for treating this disease. And here is anatomy of the pathology of phthalate. We can see the anomaly, like here, a malalignment ventricular septal defect here, it's a VSD, and here is the aorta override, and the right over, and the right, and the right ventricular outflow tract obstruction here, and we can also see the right ventricular hypertrophy. And interestingly, here is a PDA. Here you can see the PDA. The question is PDA helpful for these patients or not? Actually, it helps the patient to make more blood flow into the pulmonary artery. So it is good for the patient. Pathophysiology. Systemic venous blood through the VSD to mixed with the systemic cardiac output. And we can see the blue baby here. A blue baby is an infant born with a congenital heart defect. The defect prevents oxygen-rich blood from circulating to the body, which gives the infant skin a bluish tint. And the clinical manifestations include increased activity and increased cyanosis, polycythemia, and the dyspnea, murmur, growth retardation, clammy finger, hypoxic episodes with crying, and the knee-chest position. The last one is very typical for these patients. You can think about the reason why the knee-chest position the patient like. The Charge-of Fat is a surgical disease. That means the natural history of untreated TOF is dismal, with most children succumbing to the ravages of progressive cyanosis before 10 years of age. Complete repair of the Charge-of Fat is like this. First, you can see the enlargement of the right ventricle to the main pulmonary artery connection with a transannular incision if necessary. Here we can see the resection of the muscle from outflow tract and identification of edge of the ventricular septal defects. And here we can see the patch closure of the VSD. It's very large VSD here. And here we can see the placement of a transmural patch of the outflow tract of the right ventricle. So the long-term complications include severe pulmonary insufficiency and non-contractile infundibulum, and progressive tricuspid insufficiency and elevated central venous pressure, hepatomegaly, peripheral edema, and the severe exercise intolerance. Next topic, we'll talk about some acquired heart disease. The first one is coronary insufficiency. You can see here the angiography of the right coronary artery like this. You can see the stenosis here and here, and it's very typical. Next one is you can also see this is the left main coronary artery here. And here is LAD, which is left anterior descending coronary artery. And here is the left circumflex coronary artery. And here is the branches of the circumflex coronary artery. We call it obtuse marginal vessels. And here is the right coronary artery here, and this is the so-called PDA, posterior descending artery. The pathogenesis of the coronary artery disease is atherosclerosis. Here we can see the anatomy of the atherosclerotic plaque. We can see the plaque like here, with a fibrous cap and a lipid core, and here is the lumen of the vessels. And the thrombosis of a disrupted atheroma is the cause of most acute coronary syndrome, result from the weakening of the fibrous cap here and the thrombogenicity of the lipid core. Reduction in luminal diameter, when it reaches 60%, the patient will have minimal impact on flow. When it reaches 75% or more, coronary blood flow is significantly compromised. Clinically, this often coincides with the onset of exertional angina. when it reaches 90%, resistance is 256 times greater than a 60% stenosis, and coronary flow may be inadequate at rest. And here we can see the coronary artery bypass procedure. Like this is the harvest of the intramammary artery. And this procedure are performed through a median sternotomy. This is the sternum. The divided sternum is lifted by the controlled retraction like this, to provide exposure, but must not be so excessive as to fracture the sternum or ribs. And dissection procedures proximally and distally until adequate length is obtained for the intended graft, and usually terminates at here is the bifurcation of the internal mammary artery. And the heparin is then administered systemically before the internal mammary artery is occluded. The internal mammary artery is prepared for grafting after transection. It's prepared like this. And here shows the technique of anastomosis between the left internal mammary artery and the left anterior descending coronary artery, LAD. The general principle used to construct all proximal and distal anastomosis. You can see here the graft is opened longitudinally to match, exceed the length of the coronary arteriotomy here. And this opening prevents kicking at the site of the anastomosis of the internal mammary artery and aorta to the saphenous vein. This opening is not necessary at the distal vein anastomosis site, but a slight bevel cut of the distal vein helps prevent kinking of the saphenous vein to the coronary artery anastomosis. And here shows the anastomosis begins midway along the side of the graft, so that the final knot will not be at the most distal or proximal portion of the anastomosis, thereby decreasing the chances of technical error that would impede graft flow. The polypropylene suture permits a portion of the anastomosis to be completed before the two vessels are joined. And here we can see the graft after the bypass graft. CVG finished like this. The radial artery graft here, the left intramammary artery here, and this is the radial artery graft. We can see all the artery graft. And here is you can see the sternotomy here. This is the sternotomy, and it can mix like this. And here is the heart exposure. With the sternum retractor. And when we do CVG bypass with off pump technique, we need a stabilization technique like this. So the local area of the beating heart can be somehow stable to make it easy to do anastomosis. This is the IMA harvest. This is the vessel here. this is how the anastomosis of the distal anastomosis. This is a stabilizer. This is a shunt. Anastomosis here. Heart is beating. Big stitch like this. This is IMA. And I will show you the shunt, how shunt working later. This is the blower to make the field clean. So the shunt is picked out. A branch of the IMA is bleeding. Like it. Pick up the stabilizer. This is how the proximal anastomosis. Here is the aorta. Type an aorta here. This is a branch. Vein. Make it open in a battle. Do the anastomosis with running suture. Down. Here shows how the shunt This is the coronary artery, the opening here. It shows inside the coronary artery to make the blood flow. Here is a blower. It's very simple. We use this blower to make the operation field clean.